Welcome, everybody. I'm assuming that you can hear me. I've just unmuted myself. I think we try and start. People will be joining as we go through, but we've got a lot to get through, so I'd like to get things started. So I'm Dr. Lena Nido. I'm a GP and I'm the GP Liaison Officer at the Royal Victorian Eye and Ear Hospital. And my usual working day is Thursday. Oh, and I've dropped my email off there, but I'll share that with you. It's lena.nido@eyeandear.org.au. I'd like to acknowledge and pay respect to the traditional custodians of this land that I work and live on. I acknowledge that the land we meet and work on is the traditional lands of the Wurundjeri and pay my deep respect to Woy Wurrung elders past, present and emerging, and to all elders of the Kulin Nation. I'd definitely like to thank all of these people and organisations. So our speaker, Ms. Elizabeth Rose, who has presented many times for us and is very generous with her expertise and time. The Collier Charitable Fund, who have generously donated funds that support our GP education program. The Northwest Melbourne PHN, without whose help we couldn't bring these events to you. They handle all the registrations, all the ROCGP points, all of the background help, and we're very, very grateful to them. Okay, now just please maintain that you are muted throughout the presentation. Any questions that you have, please type them into the chat box. I'll be moderating that. If it's relevant to what Libby's talking about at the time, I'll interrupt her. Otherwise, I'll leave all questions to the end. But please put them in as you think of them so that you don't forget. The session is being recorded. And please ensure that you join the session using the name that you registered with, because that's the only way that we can mark your attendance. And here is how to change your name in Zoom if you haven't, if it isn't saying the name that you registered in. Click on participants, click on your name, hover over your name and click the three dots. And if it's a Mac, hover over your name and click more. Click on rename, enter the name you registered with and click done, change, rename. Do feel free to ask questions as we go, as I said, but stay on mute. Please type them into the chat box. And I'm going to really quickly run through this. Is just a brief screenshot of our hospital website, the information under health professionals for GPs. There's referral guidelines and forms, education, training and past recorded events are here. There's also some primary care management guidelines and other useful links and contact information. We also have a referrals page that's got referral guidelines, ophthalmology, ENT and the cochlear implant clinic, referral forms, numbers and emails, fax numbers, etc. to send your referrals to and other important information. And just on a note on referrals, I think the last webinar I mentioned that e-referrals are coming. They've been slightly delayed, so they're coming next year. And yes, so that'll happen seamlessly through your medical software package. Or if you don't use medical software package, anyone with a web browser can use e-referrals. I'm also just going to very briefly mention the fact that the Department of Health has asked hospitals to move towards day stay for tonsillectomy and adenolidectomy as a general rule. And then, of course, with varying exclusion criteria, our hospital is currently working on this process and protocols, including exclusion criteria actually reasonably sound from what I can tell, including not for children or high-risk patients, anyone at risk of bleeding, anyone with obstructive sleep apnea, etc. And when that does go live, I will notify with my newsletters. It'll be available in our referral guidelines on our website. So make sure also that you sign up to my emails if you aren't on my emailing list. I'm just going to run you briefly through health pathways. I think most of us are familiar with what health pathways are. They're clinical practice guidelines as well as referral pathways, and they've been localised. They've been written by GP editors with input from subject matter experts. This is a screenshot of the Melbourne health pathways. Let me go back. Sorry, jumping around, apologies. If you go onto the Melbourne health pathways and you look under child health, ENT and hearing, there is a pathway on snoring and obstructive sleep apnea in children. I've already talked about that. In order to get access, you can go to Melbourne Health Pathways and you can click on the Register Now button. If you are not in the Northwest Melbourne or the Eastern Melbourne PHN catchment areas, you can contact your local PHN to find out how to get access to your local health pathways. So these are the relevant and related pages that are available on the Melbourne Health Pathways. Most of the paediatric pathways are in fact statewide, so every region will have similar pathways, but they'll be localised for that region. And this is a screenshot of the Melbourne Health Pathway, snoring and obstructive sleep apnea in children. They all have standardised layout and formats with a bit of background, assessment, management, and then information regarding referral. One of the things I do want to point out, and because there's a screenshot, I can't open it up, but if you're referring publicly, and Libby will talk about this as well, check the criteria, but if you check on the statewide, the Ionia Hospital comes up, but there is a information there saying that children with obstructive sleep apnea should not be referred to the Ionia Hospital for tonsillectomy, and Libby will explain why. And so the other alternatives of where to refer to are available there on that pathway. It's my great pleasure now to introduce our speaker, Dr. Elizabeth Rose. She's an otolaryngologist at the Royal Victorian Ionia Hospital. She's head of our paediatric clinics. She is an otolaryngologist surgeon at the Royal Victorian Ionia Hospital and recently retired after 27 years of service from the Royal Children's Hospital. She's also a senior lecturer with the University of Melbourne in the Department of Otolaryngology. So I will stop sharing my screen, or Libby can just go over the top of me. And I'll mute myself now, Libby, and give you the floor.
Okay. Thank you all very much for coming, and thank you, Lena, for asking me. We've tried to align this as much as possible with those health pathways, but perhaps with a little bit extra. So the plan for this evening is definitions, etiology, natural history, how you do clinical evaluations, possible investigations, treatments, some long-term possible concerns with surgery, a plan for management, And then a little bit more about possible behavioural sleep problems. I've got several slides of resources and references at the end, but for all of the slides, I've got, or for most of them, I've got a reference so that you can look something up. 27% of children have habitual snoring, so not just with a cold. And snoring is the noise that is made during sleep from airflow, fluttering the soft tissues in the nasopharynx. And part of this is because there's muscle relaxation in sleep. So you get the occasional young child who definitely snores awake because their tonsils and adenoids are so large. But most children with sleep apnea do not have a lot of noise while they're awake. It's more likely to occur in children who've got large tonsils and adenoids. It's the major component for most children. And the tonsils and adenoids grow most quickly in those preschool years. And for some children, their adenoids are quite large by the time they're 12 months. So sleep disordered breathing is a spectrum of sleep disorders, but they all have a degree of upper airway obstruction, but differing degrees, but also differing clinical consequences from that. So we recognise the primary snoring, which is in about 10% of young children. So they're snoring, they don't have obstructive symptoms, and on sleep studies, they don't have any changes in their gas exchange. And then the worst part is the obstructive sleep apnea, which is estimated to occur in about 5% of all young children. And then in between that, there's these other upper airway resistance syndrome. So primary snoring, 70% of children with snoring have got this condition where they don't wake up a lot, they don't have changes on their polysomnography, and they don't have daytime symptoms. So those children can be quite happily maybe treated. We'll talk about treatment, but it's unlikely that they will need to have an operation. The upper airway resistance is where there is some limitation of airflow, but they don't meet the full criteria to say, oh, this child has obstructive sleep apnea. However, children with this milder form can still have daytime symptoms and other manifestations like tiredness and poor school performance, suggesting that they have obstructive sleep apnea. And they can have the same neurocognitive behavioural concerns, and there are quite a few studies that indicate this group of children can also benefit. Most of them are talking about children having surgery, but can certainly benefit from having treatment. So the obstructive sleep apnea, repetitive episodes where there's obstruction while asleep with hypoxia, sleep disturbance, possible hypercapnia, and arrhythmias. And it's very important for your learning and behaviour and cognition, but also cardiovascular health. So the peak age is 2 to 8 years, and this coincides with the time where your tonsils and adenoids are getting larger in size, but also the midface is small. And if you look at the children in kinder and starting school, they've all got big forehead, tiny face. And then if you look at the children in grade 5, 6, they've now got a face and a nose. Early onset of this is much more common if the child was a premature baby, conditions such as trisomy 21 with midface hyperplasia, children who attend daycare, the African children, but there's also associations with tobacco exposure and also obesity. So pre-puberty, the number of girls is the same as the number of boys, but after puberty, it's more common in boys. So the tonsil and adenoid hyperplasia, influenced by the microorganisms, but it's also the immune response to those challenges as well. And there was an interesting paper that indicated that children with tonsil hypertrophy receive a greater amount of their daily calories from sugar, soft drinks, and edible fats. And these were children who were normal weight compared with children who do not have sleep apnea. And they just had a bigger proportion of their diet was from those sorts of foods than the children who were similar weights and ages but did not have sleep apnea. So I think you'll be familiar with this. They talk about Waldayer's ring. So this is a view, from above with the tongue at the front. The tonsils, the palatine tonsils, are the ones on the sides. There's the adenoid, also called the pharyngeal tonsil. There's lateral lymphoid tissue, including around the eustache tissue. And then sometimes the lymphoid tissue on the back of the tongue, the lingual tonsils, can also become quite large. So this is called the mucosa-associated lymphoid tissue, and it's where the breathing and swallowing occurs. And it is a defense mechanism for antigen sampling, but also for triggering the immune responses. So we look at three kind of main groups. There's the children who have marked tonsil and adenoid hypertrophy, easy to see when you examine them, but normal or low weight. There's the children with obesity, and often the young children do have upper airway lymphoid hyperplasia, but perhaps not as big as some of the other children. But importantly, 50% of obese children do have OSA. And then there's a group of children with the craniofacial abnormalities, neuromuscular disorders, who also have the OSA. So there's a combination of the anatomical problems, but also the neuromotor factors, so structural and a collapsible airway. So the effects, central nervous system, cardiovascular, metabolic, somatic growth, and quality of life. So the neurocognitive and behavioural deficits, this doesn't happen in every child. They can have daytime hyperactivity and inattention, and that's thought to be because of their sleep fragmentation. They may not actually wake up, but they have these times where they're in a much lighter sleep, so they don't get the good solid sleep that they need. And this fatigue makes them irritable, and some of the children are actually labelled as being hyperactive when they're actually an irritable child who's not getting enough sleep. They often have impaired concentration, so poor school performance, but also just reduced interest in daily activities. So often parents will say, he used to like to go swimming after school, or Thursday is his footy night, but he doesn't want to do that anymore. Interestingly, there's still uncertainty about whether, if you have OSA of a longer duration, so you have it since you were very young and don't get treated for a while, or if it starts early, if that makes these conditions worse. But you would think it would if you've got OSA for a longer period or start earlier, that would have a bigger effect on your cognition. Cardiovascular, and there's increases in their blood pressure during obstructed sleep, and it doesn't always improve with treatment, so it can lead to lifelong hypertension. There can also be left and right ventricular wall thickness, which is seen on an echocardiogram, and it's from changes in the pressure in the chest, but also hypoxia causes increased pulmonary artery pressure. Those changes can be reversible once a child is treatment. So the implication is that there's very real benefit from detecting OSA early and And then the metabolic changes and insulin resistance, elevation of the low density lipoproteins and cholesterol, and that's particularly in children with obesity. But failure to thrive, that's not a huge number. Only about 5% of the children aren't thriving, and it's because of increased energy use during the night because they're working harder at their breathing. Often their nose is really blocked, and they've got big tonsils, so it's harder for them to chew and swallow. But also you produce growth hormone during the deep stage 3 sleep. And because that's what's reduced if they've got obstruction, they're not secreting their growth hormone. So this is the natural history. Around about 40% of children who snore when they're young without treatment will continue to snore as an adolescent. So 60% of children will improve. It's a bit worse if you're male and have a higher BMI. So facial growth is slow up until about 8 years, and these are some skeletons of an infant, and then you can see how the child at 6 has still got a small face, but by the time they're 12, there's a much bigger face, and that includes the nasopharyngeal and oropharyngeal spaces. And there's still a lot of change that goes on in the proportions to get to the adult. And also after about 8, there's reduction in the immunological function in the tonsils. And so they actually, both tonsils and adenoids can reduce in size. So the clinical evaluation of the snoring child, it is a bit difficult, not completely reliable for the diagnosis, but can be really suggestive. And the findings are on a bit of a continuum, but we do have some red flag findings that clearly correlate with OSA. So the more red flag findings a patient has, the more severe they are, the greater the likelihood of OSA. So these are the ones that have been identified. Snoring or noisy breathing during sleep for more than 3 nights a week, and that's without a bad cold. Difficulty breathing while asleep, so choking, gasping, they're sometimes restless and sweaty. Patients who report parents who report they're afraid of their child's health because of their breathing, and frequent daytime mouth breathing and difficulty swallowing. And then clearly witnessed obstructive sleep apnea. And they just make this little proviso down here that young children in particular will have central apnea, so they will often have a pause in their breathing, but they're not trying to breathe. If you've got obstruction, you'll go and your chest is trying to cave in, whereas if it's central apnea, they'll just have a pause and they won't be attempting to breathe. They may sleep in unusual positions, that they will prop themselves up. They do that themselves, put themselves up on some pillows. I had a young girl with trisomy 21 who sat cross-legged next to the bed, so she put her head down on the mattress like that, and obviously her brain told her, if you lie down, you'll obstruct. So she slept like that for some years. And then secondary enuresis, not enuresis per se, but someone who has been dry for 6 months and then develops enuresis, that could be sleep apnea. This OSA 5 score, you may have heard or read about the OSA 22, which then became the OSA 18, and that was a validated score. But these are paediatricians who work here in Melbourne, and they developed this OSA 5, which is so much easier and quicker to administer. And if you add up snoring, breath holding, choking, mouth breathing, breathing problems that make you think your child's not getting enough air, and if it's a score under 5, they probably don't have obstruction, and if it's higher than 7, they probably do. But Kathy Rowe, who was one of the paediatricians, she said But he thinks the question, if you're only going to have one question to ask this one. Does your child have breathing problems at night that you are worried that they're not getting enough air? Do you reckon that's the one that you really need to ask? The differences between adults and children. Children tend not to have an obstructive episode. They can, but they tend to just have reduction in flow called a hypopnea, where they are breathing, but it becomes much more shallow and very noisy. And then they will often reposition themselves. They then go, and they reposition themselves so that they can breathe better. They're not commonly sleepy. We'll see some exceptions to that. They're usually normal weight, but obesity increases the risk, and boys and girls are the same. This paper looked at the differences for children who are obese. So they named them type 2 and type 1 being the children of normal weight. So you can see that the children with obesity are much more likely to have daytime sleepiness, whereas the children of normal weight are much more likely to be labelled as being hyperactive. The obese children also are much more likely to have the cardiovascular problems and the metabolic problems. And it is a bit tricky that there's definitely an overlap between the behaviour and attention deficit. But I had a child a while ago who's genuinely autistic child with severe OSA. And his father actually called me a few weeks later to say he was so much better. He's still an autistic child, but because he now gets the quality of rest that he needs, his behaviour was so much better. So clinical examination, weight gain, do they have a craniofacial problem that you can see? Is there pathology in the nose? Examination of the tongue. I've got a picture of this, a pectus excavatum. I think this was included. This was a really good article in Australian Family Physician, but they included ventricular hypertrophy and pulmonary hypertension. I don't think, unless you're a cardiologist and can, listen to changes in the second heart sound, I think that's very hard to diagnose. I also think testing for hypertension in young children, I find that very hard, but, for a 2-year-old to sit there and be still, that's a difficult part of the examination as well. So examination. Often the obstruction is at multiple levels. So here's a young child sleeping with his neck extended. He's got a smallish jaw. He's got big adenoids and tonsils and may have large lingual tonsils as well. So this is a child with apoetic craniofacial syndrome. We often talk about children having a high palate, which he does have a very high palate, and you can see how that palate would encroach on the nasal airway. When you look into the nose from the front, you will often see, as the first thing, large inferior turbinates, but it's very hard to see more just from outside, but it would be very unlikely you'd be able to see the adenoids looking from the front of the nose. You can look from below, the dog's eye view, that you might see that there's the septum pushed over. You can push the tip of the nose back with hopefully a gloved thumb and see quite a lot in there. And you can also just use a regular otoscope to get a view. So there's a nice normal mucosa, nice and pink, not very swollen. With this one, you can actually see the middle turbinate as well as the nasal septum. Here's the allergic sort of mucosa where it's very pale and boggy mucosa. We often get patients referred saying, oh, they've got a nasal polyp, but a polyp does look different from a turbinate, and polyps in children are actually quite uncommon. So the Brodsky scale for the size of the tonsils is probably one of the most common ones used. So the grade 0 is where the tonsils have come out. The grade 1 is when they're still within those tonsil pillars. And then 2 occupies 25 to 50% of the oropharynx. I kind of look at that as the half of the pharynx. I say, okay, it's less than half there. Then the grade 3 and then the grade 4 where they're really large. But I find there's a lot of overlap between the grade 2 and 3, I think. So, what I might say, oh, that's a grade 3. Someone else might say, oh, no, it's only a grade 2. These are ones where you might say, oh, look, those are small. But in fact, the tonsil is out here. And we kind of call them endophytic or innies. And these are the exophytic, where they're just hanging on a very thin pedicle. And those are clearly, flopping into the airway. The other tricky thing is, this is someone with big tonsils already, but you can see how when you put in the tongue depressor, they look much, much bigger. And the same with this one. The tonsil there, that's not much tonsil, but in fact the tonsil is out here. And when the patient stuck the tongue out, you can see that they are much bigger than they look there. That's what the adenoids look like when you put an endoscope down the nose, a big chunk of adenoid tissue in the nasopharynx. And they do show up quite nicely on a plain view. And these are the lingual tonsils. This is looking from above. So you're looking down and then you go down into the airway there. So there's the epiglottis. And this is a big lot of lingual tonsils on the back of the tongue. You might have someone who's still got congenital problems. A child with choanal atresia, if they're bilateral, they'll almost always present like within hours of life because they can't breathe and can't feed and breathe. There's the nice normal nasopharynx. But you can have children with unilateral choanal atresia who present later in life. And then the piriform aperture stenosis, there's the normal piriform aperture, and this is a much more narrow. And again, they will usually present in the first few weeks of life with problems. And that's a test excavatum where the sternum is being sucked in because of the negative pressure within the thorax. So possible investigations, home oximetry, polysomnography, home video. Home oximetry is really quite well available. Both Monash and the Royal Children's have these. As doctors who don't work there, we can actually refer direct to get the home oximetry. It'll probably be a few weeks, but it won't be months or years to get them. They're useful if there's hypoxia. So this is a patient where they've got multiple times, they've got oxygen desaturations, but it doesn't measure sleep fragmentation. So the child could still be having a restless night, but it won't show up. The polysomnography is much more involved and almost always needs to be in a sleep laboratory. And you can see how they need to be all wired up for it. And it's really not a natural sleep. And often parents say, he just didn't sleep in the lab like he would have at home. But it's objective, you can quantitate it, so you can compare it now and compare it after treatment. You can stratify into severity. But it is a high cost, intense labour, a family burden. Some of the labs, there's a cost. If you have private insurance, they can be done. There's a group at the Epworth who can do them. But for polysomnography, that has to be referred by a respiratory physician. Home videos can be very useful. Oh, sorry, okay. So, back, here we go. It's a bit quiet, but it gets louder in a moment. And you can see how the child is trying to breathe. You can see his neck going in. And really not moving air there. And then he takes a big breath and he repositions himself so he can breathe. So those sorts of ones can be very useful to ask the parents to do that. So management options. This was a study we did here in Melbourne. The effectiveness of intranasal mometasone and saline for sleep-disordered breathing in children. And we found that almost 50% of the children, whether they had saline or whether they had the nasal steroid, 50% of them went from having been assessed as probably requiring tonsil adenoidectomy to not they will not need to have surgery. There's an ongoing study with this, and I'll give you the details of that. So that was published in January. So tonsillectomy and adenoidectomy is still mainly what we do, and the success rate is 82%. So improvement in their sleep-related symptoms, but also in their quality of life. But unfortunately, not all children will have improvement in their neurocognitive functioning, and only 82% of the children will normalise their polysomnography after surgery. It improves, but often it doesn't resolve the OSA in the majority of obese children. And children with chronic asthma also are less likely to have incomplete resolution of their symptoms. And I know that's sort of disappointing, but I had a child a while ago who had trisomy 21, but his pre-op polysomnography was extremely severe OSA, and his post-op was extremely mild. So we all said, that's fine, that's okay. We may not have cured them, but we have improved them, and hopefully have helped to resolve some of those cardiovascular complications that can occur. So other possible treatments depends on the clinical evaluation and results of sleep studies. And although dental appliances are very useful in adults, we've not been using them in Melbourne. We have discussed this with the dental department at the Children's, and they are concerned about making splints because they're concerned that they will actually possibly stop the natural growth, but also because children grow, then they'll need another one, and that start getting very expensive for the families. This is an interesting paper, and it was in response to we often get referrals from dentists saying this child's got a crowded dentition, it's because of their tonsils and adenoids. Could we take those out to improve their maxilla? And this study showed that if you do tonsil and adenoid surgery, even if you make those symptoms better, that does not change the growth of the maxilla. So when we see children with that, we do surgery if they've got obstructive symptoms, but not if they don't. So this is what that looks like. They have appliances to their teeth, and then they have, and it can be both maxilla and mandible. There's a little screw that they screw to expand the palate and expand the mandible. Children with the craniofacial anomalies, this child was about 9, the child with APERS, and you can see what a difference that's made to his face, but clinically he was so much better with his airway and his breathing, and was no longer tired afterwards. And then, continuous positive airway pressure, really if all else fails, or there's a reason why the child can't have surgery. Really rare to need a tracheostomy, but occasionally we've had children with really significant craniofacial problems who won't be able to have their expansions, till they're 9 or 10, and the only way they can have a good airway is with a tracheostomy in early childhood. But that's really extreme. So there are perioperative problems, and possible complications from their general anaesthetic. I'm sure you're all aware of the significant pain. They get sore throat, tongue referred to their ears. They can all get dehydrated, initial weight loss, bad halitosis. But chest infections post-operatively are quite common. Some of the children will need respiratory support on the night of surgery, and the need for special care wards. It's possible to have bleeding, return to theatre, possible blood transfusion. So there are significant perioperative concerns. But this is something that's becoming a bit more in the literature now, possible long-term complications. And I often think that I am like Winnie the Pooh. When you're a bear of very little brain and you think of things, you find sometimes that a thing which seems very finished inside you is quite different when it gets out into the open and has other people looking at it. So I need to discuss with, all the brains people, which for Pooh was, rabbit and owl. These are some fairly recent articles, and you may have seen this one. This was the cancer risk following surgical removal. This was only published in May this year. And then there's been quite a few about possible risk of respiratory allergic infectious diseases in children who have their tonsils out. So this was the infectious diseases one, and they indicated that children who have their tonsils out have more rhinitis, but also urticaria, so more allergic type problems, but reduced tonsillitis. And adenoidectomy also associated with increase in diseases of the lower respiratory tract. And different papers, some of them say if you have your adenoids out, you produce less IgA, but other studies haven't shown that. And then this was probably of great concern as well, was the cancer risk. And it was a definite increase. So they compared families, so a sibling who did not have their tonsils out, and although the siblings also had an increased risk, it was not as great as the risk for the child who did have their tonsils out. And again, reduced risk of things like ovarian cancer, testicular cancer, but also no risk of tonsil cancer. So this is a meta-analysis, and they decided that although there was some evidence for increased infections, there was more evidence to suggest that there's no negative immunological or clinical problems. And it was a very careful paper from an immunologist who just said the tonsils contribute to immune cell development differently for different people, and that having large tonsils could mean that you are at a greater threat for oncogenic pathogens, but also your tonsils are more immunologically active than some other people's tonsils, and that maybe you are the person who shouldn't have their tonsils out, whereas another person would be fine. So I think I am concerned about this, and why I'm probably a bit conservative about just taking tonsils and adenoids out, but it's something I think it's not entirely clear yet. So, management plan. Do the OSA 5 score. If it's severe, refer them straight to either Royal Children's or Monash, depending on where you live. Do the topical saline. I think this is really safe. Topical saline for 6 weeks. If there's no improvement, then change to the topical nasal steroid. Children older than 2 can have fluticasone, which is the Avamest. Older than 3, mometasone, which is Nasonex. You need a prescription for fluticasone, and under 12 you need a prescription for Nasonex as well. Oral montelukast, the child also has asthma. And then after either the 6 or 12 weeks, repeat your OSA score. So you've got something a little bit objective. This is a nice video from the Royal Children's. I actually showed this to the family in the room about how to use a nasal spray. Discuss diet, and I think this is something I certainly don't do well at all. But this is the things that, and I point out that these are things that to protect your immune system, you should avoid the high fat, high sugar, low fiber food. You should encourage the other sort of foods, particularly the vegetables. And you really do have to ask, because often they'll say, oh, he loves his fruit, or he always eats his broccoli. And then you say, well, what did he have yesterday? And you find they didn't actually have any vegetables at all yesterday. So you do have to ask in some detail. And this was just an example. So I'm not sure about the anti-inflammatory diets, but I think everyone feels that the processed foods, deep fried sugar foods, cause inflammation in the body, whereas the fresh green fruit, vegetables, nut paste, I say nut paste because I worry about inhaling nuts, but those are the healthy foods, and sort of concentrate on reducing inflammation. And the Raising Children Network's got some great resources for all age groups. So there can be a less clear clinical picture. Possibility of comorbid sleep problems, and there's uncertainty really about what is the sleep duration for children, and it may be more important, do they go to bed well before midnight rather than saying, oh, they stay up till midnight but then they get up at 9, and do they have a good solid sleep, or is it fragmented? And those factors may be more important than their actual duration. So if they have trouble going to sleep, or they wake a lot at night, or they wake early in the morning, or any of those, then the recommendation is to refer to a sleep physician for assessment. So if they have significant obstructive sleep apnea clinically, refer to the Royal Children's or Monash Children's rather than to the INEA. And these are our kind of criteria for the INEA. We'd like them to be 4 and older, not have significant comorbidities. And there were those ones of prematurity, heart disease, obesity, preferably give an idea of their weight or their BMI in the referral. Clinically severe OSA, because these children, there's an increased risk of postoperative respiratory complications. And this is even a child who's now 8, who was a preemie baby, they still have increased risk of complications on the night of surgery, may need monitoring intensive care, may even need re-intubation or oxygen. So where they have their surgery should reflect that those are increased risks for those children. So my summary, snoring is common in childhood, key symptom of OSA. OSA has an adverse impact on sleep quality, daytime functioning, cardiovascular health. Children with even mild sleep disordered breathing can have neurocognitive behavioural concerns and will still benefit from treatment and even tonsil and adenoid surgery. Treatment with adenoid tonsillectomy is usually effective. And anti-inflammatory agents should be considered for children with nasal obstruction and mild symptoms. But I would actually start everyone on those treatments while you're making your referrals. I'm just going to advertise for the MIST trial. This is the second part of the trial being done through the MCRI. So children who you're thinking, I'm going to have to refer this trial, you can show this to the parents. If you contact Deb Anderson, she'll send you a laminated poster for the office waiting room or to have in your office, because we like to have more children involved. And then at the end of this, I've just got the resources for sleep and the references, and just a bit more of the things I was talking about with the OSA and that paper from the immunologist. I was just acknowledging where I got my red flag, and thank you for your attention. So I think I might mute, or we see what's in the chat, Lena.
I don't have any more. Oh, that's echoing, so I'm sorry. There haven't been any questions that have come into our chat box, so there's a few more minutes if anyone wants to type a question in. Because it was so comprehensive, Libby, that, you know, everyone's been so well informed. That was great. Obviously, for me, the fascinating things are the trial with the intranasal saline versus intranasal corticosteroids, and that you got very similar results. So that's awesome.
That was surprising, which is why we've gone into phase 2. Yeah.
Yeah, that's very interesting. I don't know. There's certainly no questions coming up in the chat box, and we do have 7 minutes left on the clock, so that's good. I should have had some pre-prepared. I guess what I will do is just get you to go through, in particular, so the referral criteria again. My understanding was pretty much any child with a sleep disordered breathing was not a candidate for coming to the eye and ear hospital, but it looked like there was maybe some wiggle room.
I think so. I think one of the problems is there's a lot of children who are snoring, but not clearly obstructed. So they're still breathing. They're minor kind of symptoms of perhaps being some daytime tiredness or irritability, but they're not clearly obstructing at night. They don't have these other problems. And I find this really hard to, you know, discriminate against people because of the obesity. And I had a family, you know, their 4-year-old weighs 40 kilograms. And I said to them, we just won't be able to manage him at the eye and ear. We don't have the intensive care and the monitoring to manage him. And the mother said, well, he's only big because his parents are big. And I thought, well, yeah, this is right. But it's still, that's still not a reason to say, well, he's going to be safe being done at the eye and ear. And just in terms of, you know, managing the anaesthetic, I find 4-year-olds are very excellent people. They understand what you're telling them. They'll tell you if they're in pain, if they're hungry, they want to eat. They're very easy to manage, and they're often easier to manage than a 7-year-old. And they're certainly easier to manage than a 2-year-old. And I do think those really young children should be in a paediatric hospital. Yeah.
Yeah. And
so we're not refusing to treat children who snore, not at all. No.
Yeah. I guess we just, for those who aren't completely aware, the eye and ear hospital does not have an intensive care unit, is basically what we're getting at. I had another question for you, so I'll have to come up with them myself. Post-operative pain management, what's your go-to, Libby?
Yes. So I've lost my view of you. Perhaps I'll end my show. Oh, no, you've come back. Good. We did some really good program through Safer Care Victoria. Yeah. And it's on their website that we advise that they have some pain relief 4 times a day for a full week, and advise that they might need to have it for longer than that, and not to be worried if their child is still needing pain relief at day 10. So the standard is paracetamol 4 times a day. We do give celecoxib. I think most of the children's hospitals, we have it here at the Ioneer, and the celecoxib is used because it's a twice a day dose, so it kind of gives you a background of pain relief, and then you can add on the Panadol. It's safer than the Nurofen, but I think more and more people are thinking that Nurofen is probably safe. The studies on Nurofen showed that not that you have an increased risk of bleeding, but if you bleed, then you probably have more bleeding, more risk of going back to theatre, possibly more risk of having a blood transfusion, but doesn't actually increase the risk of bleeding. And then for children who don't have significant OSA, they can definitely have some oxycodone. You're probably aware that codeine has been banned, and if patients, occasionally an outside doctor does prescribe that, it's clearly written on the bottle of, don't give this if your child has had their tonsils out. So we stick to those sorts of simple things. The other thing that was very useful that we instigated was a chart, a medication chart that the parents could tick off when they gave it, because for so many families, there's one parent home now, but then they go to work, or maybe grandma comes for the day, or they go to a different parent over the weekend. There is one parent in the week, a different parent on the weekend. So they can see easily, oh, this is me due for this. Now the child's in pain, I can give them this. One of the really interesting things that came out of that, because we did a lot of studies, but probably the best thing for getting a good outcome was if they had nurses on the ward who explained things really well to them. So a good explanation of what to expect really worked. The other thing that really surprised me was about a third of the children said that ice cream and icy poles are too cold and they didn't want them. I thought, what? No, I'm in trouble, because we always say, look, if you're in trouble, give them an icy pole, so that will be all right. So that was all very interesting. But it is, and I think if parents know this is going to happen, and we say, buy your Panadol before you come into hospital, don't go and buy it on the way home, get it in. The other interesting thing is that antibiotics don't help. It's not like, and we know they will all get terrible breath and it looks white and dreadful, but that's not because of a bad infection. And, that there's no evidence that if a child's given antibiotics that will prevent them from having a bleed. It may improve their chances of eating better after a few days, but it's not huge. And it's just another thing to get into them as well.
Yeah. Excellent. All right, there's no more questions, so I'm going to share my screen just to go. Just to share my final slide. So the QR code there links to our feedback questionnaire. We really value your feedback. Please fill that in now while it's fresh in your brain. Also, participants will receive a post-session email within about a week, which will have slides and resources discussed during this session. Attendance certificates will be received just over a month, 4 to 6 weeks, and the points will be uploaded. RSCGP points will be uploaded within 30 days. This session has been recorded, so you will be able to view it again, either on the Northwest Melbourne PHN resources website, or we'll also post it on the Ioneer Hospital website once that becomes available. Please don't forget to sign up to my emails. If you're not already on my emailing list, please send me your email address at gpliaison at ind.org.au. This was our final GP education event for this year, but we'll be planning our sessions for next year. And if you've got any suggestions for what you'd like us to cover, very happy for you to email me that. That's really all I've got to say, apart from thank you so much to Ms. Libby Rose, who's really presented a great, really informative presentation and has done so multiple times for us in the past. So I'm really very grateful to you, Libby. Thank you so much to Yvonne Bessie at the Northwest Melbourne PHN for all of your support and, you know, tirelessly working away in the background. And she'll be the one organising your points and emailing you and such. So very, very grateful to you all. And for all you guys logging on in the evening after a busy day, I know it's not easy. So I think unless anyone's got anything else to say, I'm going to sign off.
Lovely. Thank you, everyone. Bye-bye.
Yeah, great. Thanks.
Thank you, Lena. Thank you, Libby, for a great presentation.
Thank you.
Thanks, Yvonne.
Thanks, Yvonne.